Hello and welcome everyone. So today I am with another lecture for PDCET pediatric students for this 2026 exam, which is on 12th of April. So I guess all of you are preparing well now, and all of you have mostly taken leave from your workplaces because last minute revision is always very much essential for any exam, especially of MCQ pattern. Because whatever you have done, you have to revise at least three times. So first reading, casual reading, second reading with the purpose of learning, and then third reading is very much important, which is basically revising all the facts. So now very less time is left, and in this lecture we will try to cover few important topics of pediatrics, which are supposed to be asked in any MCQ exams, and they have been asked previously in NEET PG many a times. Yesterday, we have uploaded a lecture with 100 important one-liners, and now today we will start with this last-minute revision for PDCET pediatrics. So first is Apgar score. Everyone is well aware of this. So parameters, there are one, two, three, four, and five parameters. Each parameter has been given scoring from 0, 1, and 2. Minimum score is 0 and maximum score is 2. So first we will look for appearance, that is color of the baby. Blue or pale all over, so score 0 is given. The body is pink but extremities are blue, that is acrocyanosis. The score is 1, and if the baby is completely pink, the score is 2. Another is pulse, that is heart rate. If it is absent, then 0 score. Less than 100 is 1 score, and more than 100 is 2 score. Grimace, that is reflex irritability. If no response, then 0. If grimace or weak cry, then 1, and cry, cough, or sneeze. So score is 2. Activity or muscle tone, if the baby is limp, then 0. If some flexion is there, then 1. And if the baby is moving actively all the limbs, then score is 2. And the last one is respiration. Respiration, if it's absent, then 0 score. If slow or irregular respiration, then 1. And if the baby is having a good cry, that is, he's breathing very nicely, then the score is 2. So, Apgar, A for appearance, and pulse, P for pulse, G for grimace, A for activity, and R for respiration. So, these are the scoring. And score 7 to 10, normal baby. 4 to 6, moderate distress, may need resuscitation, and 0 to 3, severe distress, immediate resuscitation is needed. So, few important points about Apgar scoring. It's done at 1 minute and 5 minutes. MCQs have been asked previously. So, 1 minute and 5 minutes, and repeat every 5 minutes if it is less than 7, because more than or equal to 7 is normal. If it is less than 7, then we need to reassess. And if it is less than 3 and severe distress, immediate resuscitation should be started. Okay, maximum score is 10, as 5 parameters are there in each. Maximum score is 2, so total maximum 10. Most important parameter is heart rate. Apgar does not predict long-term neurological outcome. It is used to assess need for immediate resuscitation. So it can be asked in MCQ, different options, and which is not correct, or that sort of MCQ can be framed from these lines. So it does not predict long-term outcome. It is used for immediate resuscitation purpose. Second topic is teratogenic drugs. We will have a look at few important teratogenic drugs. Thalidomide, every one of you know well. It causes limb defects, so phocomelia. Valproate, it causes neural tube defect. It is important because case-based question can be asked that a female 30 years of age with epilepsy since last 10 years is on sodium valproate, delivers a child, and which teratogenic effect is suspected. So neural tube defect entities are common with sodium valproate. And warfarin, it causes nasal hypoplasia and stippled epiphysis. So case can be formed in this way that a 25-year female, known case of rheumatic heart disease, valvular heart disease, severe metal regurgitation, is on warfarin uh, for anticoagulant prophylaxis, and delivers a child. What teratogenicity is suspected? So nasal hypoplasia or stippled epiphysis. Lithium Epstein anomaly is seen. Cardiac defect, lithium in mostly female who is having bipolar disorder is might be taking lithium, so case can be framed. Isotretinoin, most severe craniofacial teratogen. ACE inhibitors, renal agenesis and oligohydramnios, and tetracycline leads to teeth discoloration. There are many drugs, but these are the few important ones from which MCQs have been asked in previous year questions. Now, another very important is Caput succedaneum versus cephalhematoma. So, we will go through the features of both Caput versus cephalhematoma. So, definition: edema of scalp is Caput and subperiosteal hemorrhages. Cephalhematoma cause pressure during vaginal delivery. It leads to Caput. It is common. And rupture of vessels due to trauma or forceps delivery or vacuum. It leads to cephalhematoma because of subperiosteal hemorrhage. So, in normal vaginal delivery, only due to the normal physiological pressure of female genital tract, it causes edema of scalp, so it is caput. And if the subperiosteal hemorrhage takes place due to rupture of vessels, due to any birth trauma or forceps delivery or vacuum delivery, so it usually leads to cephalhematoma. Onset, caput is present at birth, but cephalhematoma appears after few hours. So you are attending a delivery and you get a newborn child just delivered and having some edema of scalp, so you should suspect caput. And extent, caput is diffuse while cephalhematoma is localized. So the very important point, which is favorite MCQ, suture lines. Caput crosses suture lines because it is diffuse, while it does not cross suture lines. So cephalhematoma does not cross suture line, while caput it crosses suture line. Consistency: caput is soft, fits on pressure, while cephalhematoma is firm and non-pitting. Skin changes, may have bruising, and normal skin in cephalhematoma. Why bruising? Because it is due to the pressure during vaginal delivery, while skin is usually normal because it is due to rupture of vessels. This Calibetova. Now, resolution in 2 to 3 days, caput usually disappears, and cephalotoma takes weeks to months. And complications, there are usually no complication of caput, while severe cephalotoma may lead to severe jaundice and calcification. So, this is very important table again for MCQ, and from all these features parameters, MCQ can be asked. Now, primitive reflexes, we will go through this fastly. First one is Moro reflex. Stimulus, as you might be doing in your everyday practice. So sudden head drop. Last one, what is the response? Extension, abduction, flexion of arms, so embracing or hugging like reflex, and it appears at birth and disappears by 5 to 6 months. Second is rooting reflex. We stroke the cheek of the baby, the turn head towards the stimulus and opens mouth. Present appears at birth and disappears at 3 to 4 months. Sucking reflex. If you touch lips, sucking movement appears at birth and disappears at 3 to 4 months. Palmar press, pressure, or if you give pressure on the palm of newborn or infant, grasping of fingers, it is present at birth and it disappears by 5 to 6 months. Plantar grasp, pressure on sole, so toe flexion appears at birth and it disappears at 9 to 12 months. Asymmetric tonic neck reflex, turn head to one side. Uh, Response in this case is to be remembered. It can be asked in MCQ for Moros and for ETNR. So what happens if a head is turned to one side? Extension of limbs on the same side while flexion on the opposite side. So fencing posture in ATNR. It appears at birth and disappears at 4 to 6 months. In stepping reflex, you hold the child upright and feet touch the surface. So stepping movements is shown by the infant. It appears at birth and disappears at 2 months of age. Now, short stature, another favorite topic for examiners. Familial short stature versus constitutional delay of growth in puberty. So, cause of familial is genetic, that is short parents, so short child. And in constitutional delay, delayed growth tempo, variant of normal development. Height is short but appropriate for family or mid-parental height. And the height is short for age but delayed growth pattern is seen in constitutional delay. Growth velocity is normal. In familial, it is normal after initial slowing. Bone age, important for MCQs, normal, that is equal to the chronological age in case of familial short stature, while the bone age is delayed in case of constitutional delay of growth. Puberty, normal timing, delayed puberty, as we have seen that growth is delayed. So, and final adult height is short because it is due to the genetic potential of parents. And final adult height is normal adult height because catch-up growth is seen later on in constitutional delay. Family history, parents are short, while history of delayed puberty may be seen in constitutional delay, so they are known as late bloomers. Weight is normal in familial, normal in constitutional, and left test are normal in both cases. Now, ORS versus ReSoMal, what is the difference? Low osmolarity ORS versus ReSoMal, full form of ReSoMal is dehydration solution for malnutrition. So, ORS is used in normal children with dehydration, that is acute diarrhea, while ReSoMal is important, it's used in SAM, severe acute malnourishment children with dehydration. So, composition of sodium, now it is again very important. while it is asked in exams, sometimes we get confused with these values. So sodium in low osmolarity ORS is 75 milligram per liter, and low osmolarity is used in ReSoMal, that is 45 milligram per liter. Glucose 75 and higher glucose is taken in ReSoMal 125, potassium 20, high potassium in ReSoMal 40. Osmolarity is low osmolarity ORS, so 245 milliosmol per liter, while it is around 300 milliosmol per liter in ReSoMal. And what is the purpose? Purpose is replace water plus electrolytes, and the purpose in ReSoMal is to prevent sodium overload in case of SAM patients. So what is the purpose of ReSoMal? To prevent sodium overload in SAM. And risk if misused, safe standard therapy. So not much of risk is there, but if given in normal child, it will lead to hyponatremia. Okay. So SAM children are usually at risk of developing sodium overload, so rapid correction is avoided. So in that case, ReSoMal is used because your sodium concentration is low. But if it is given in normal child, so there is risk of hyponatremia. So this is difference between these two. Now, few important signs of rickets. Just remember what is rickety rosary, bead-like ribs. Wrist widening is the earliest sign usually seen. Craniotapes is soft skull, that is ping pong ball feel. Bow legs and knock knees depending on age, and Harrison sulcuses groove along lower chest. Now, rapidly we will go through DiGeorge syndrome, 22q11.2 deletion syndrome. So, catch 22 is the important mnemonic we remember this syndrome with. So, C stands for cardiac defects, especially conotruncal, so tetralogy of Fallot or truncus arteriosus. A for abnormal faces, low set ears, micrognathia, hypertelorism. T for thymic hypoplasia, decreased T cells and recurrent infections. Cleft palate for feeding difficulty. Hypocalcemia due to parathyroid hypoplasia. And 22, that is deletion of the chromosome 22. So these are the important features of DiGeorge syndrome, which is also remembered with Catch-22 syndrome. And what are the important clinical features we can see here? Immunodeficiency, that is recurrent viral or fungal infections because of decreased T cells due to thymic hypoplasia. Hypocalcemia is usually seen, which may lead to tetany and seizures in early neonatal periods. And congenital heart disease, which is conotruncal anomalies and characteristic faces are seen. Developmental delay and psychotic disorders can also be seen. Now, inborn error of metabolism with their specific urine odors. So, urine odors is very important. Phenylketonuria, defective pathways, phenylalanine metabolism, and we find musty or mossy odor. Maple syrup urine disease, as we have seen in our previous lectures, branch chain amino acid deficiency and maple syrup or burnt sugar smell, isovaleric acidemia, leucine metabolism defects, sweaty feet smell. Questions have been asked previously. Tyrosinemia, tyrosine metabolism defect, cabbage-like or rancid butter smell, trimethylaminiuria, choline metabolism, fishy odor, multiple carboxylase deficiency, biotin metabolism, and cat urine smell. So at least you should remember these four. Okay, these are important. Now secondary attack rates in case of viral infections, measles, highest secondary attack rate of 90%. Varicella or chickenpox, again very high, 80 to 90%. Sometimes question can be asked to arrange these in ascending or descending order of secondary attack rates. So you should remember highest is of measles, second highest is of varicella or chickenpox, then mumps 60 to 70%, influenza 10 to 20%, COVID-19 because of recent epidemic it can be asked, so 10 to 30%, and rubella 25 to 50%. So remember of measles, varicella, and mumps. Okay. Incubation period: measles 10 to 14 days, varicella chickenpox 10 to 21 days, mumps 16 to 18 days, rubella 14 to 21 days, influenza again very short incubation 1 to 4 days, COVID-19 2 to 14 days, hepatitis A 15 to 20 days, hepatitis B long incubation 45 to 180 days. It's chronic illness. Hepatitis C again long incubation because of chronic illness. Rabies 1 to 3 months, and it is variable. It can be up to years, around 10 years. So dengue 4 to 7 days, and poliomyelitis 4 to 7 days. So important ones are measles, varicella, mumps, and hepatitis A. Okay, and dengue can be asked. So now first to sixth disease, name disease. Number one is measles. First disease, measles is known as first disease caused by paramyxovirus. Rash characteristic starts on face and spreads downwards. Koplik spot is important. Pathological finding, high fever, cough, coryza, conjunctivitis. Now second disease is scarlet fever caused by group A streptococcus, sandpaper rash. So each and every word can be converted into MCQ. It begins at neck or chest. Strawberry tongue is seen. Pastia lines is seen. Third disease is rubella Rubella virus starts with face and rapid spreads to trunk. Mild fever, lymphadenopathy, mostly post-auricular lymphadenopathy in rubella. Fourth is Duke's disease and scalentiform rash is seen. Fifth is Erythema infectiosum, parvovirus B19, slapped cheek appearance, as previously many times. Lacy rash on body may cause a plastic crisis. And sixth is Rosula infectum, HHV67. Rash appears after fever subsides. Okay, this is important. So high fever and febrile seizures are usually seen. So these are the named first to sixth disease. A level of dehydration. Clinical features for no dehydration, some dehydration, and severe dehydration. Let's first see degree of dehydration by percentage body weight loss. So no dehydration less than 3%, severe dehydration 3 to 9%, and so sorry, some dehydration is 3 to 9%, and severe dehydration is more than 9%. Some books also give like 0 to 5% and 5 to 10% and more than 10%. Okay. So now difference, general condition, no dehydration is well alert, restless and irritable in some dehydration, lethargic and unconscious in severe cases. Eyes are normal, sunken eyes in some dehydration and very sunken in severe. Ears present, absent and absent. Tongue is moist, dry and very dry. Now thirst point is important. Drinks normally, no dehydration. Drinks eagerly in some and unable to drink or drinks poorly in severe dehydration because child gets very much lethargic. Skin punch or turgor, normal. Instant return, slow return and very slow return more than 2 seconds. Urine output is normal in no dehydration, reduced and minimal or absent in severe dehydration. Now few image-based questions. Duodenal atresia, double bubble sign is seen, and one bubble is of stomach and one bubble is of duodenum. So double bubble in duodenal atresia. Jejunal and ileal atresia, triple bubble sign can be seen. First bubble of stomach, second bubble of duodenum, and third bubble of proximal jejunum. And in congenital hypertrophic pyloric stenosis, single bubble sign is seen again. And hereditary hyperbilirubinemia, if we go through fastly. So Gilbert syndrome, unconjugated, these two are unconjugated, and third one also. So these are unconjugated and these are conjugated. Gilbert syndrome unconjugated and mildly decreased conjugation, decreased UGT activity. So features are mild intermittent jaundice because of mild decrease in activity. Now Krigler-Najar type 1 unconjugated, severe defect, absent UGT. So severe neonatal jaundice and kernicterus. So Krigler-Najar type 1 is very severe. Now type 2 unconjugated but partial defect, decreased UGT, so less severe. So this is important MCQ point, which is the most severe one of unconjugated varieties of Krigler-Najar type 1. Now, Dubin-Johnson and Rotor syndrome are conjugated, and Dubin-Johnson with impaired excretion, defective MRP2 receptor, black liver, mild jaundice. So case can be asked if my black liver in autopsy. So the case can be formed like this for Dubin-Johnson syndrome. Rotor syndrome conjugated storage defect and defect in hepatic storage and mild jaundice and no pigmentation seen in Rotor syndrome. So here Klinger-Najar 1 and Dubin-Johnson, these two are important varieties. Now difference between nephrotic and nephritic syndrome, very important. Primary problem in nephrotic is increased glomerular permeability, so protein loss. Nephritic is inflammation of glomeruli. Proteinuria, massive. In nephrotic it's massive, more than 3.5 gram per day, while in nephritic it's mild to moderate. Okay, and third point is hematuria, absent or minimal in nephrotic, but it is present. So cola color urine is pathognomic for nephritic syndrome. Edema, severe or generalized anasarca because of massive protein loss, while it's mild to moderate in nephritic. Blood pressure, normal or mildly increased in nephrotic, while it is markedly increased. It is severe hypertension in nephritic. Serum albumin is severely decreased in nephrotic because of severe proteinuria, while it is markedly decreased in nephritic. Lipids, hyperlipidemia in nephrotic, while it is normal in nephritic. Urine findings, fatty cast or oval fat bodies, while again RBC cast because of we can learn because this hematuria is seen, so RBC cast is seen. Urine appearance, rhoddy urine because of massive proteinuria, and smoky or cola colored urine because of hematuria. And renal functions usually preserved initially while it is impaired in nephritic. And common causes, minimal change disease in children and post-streptococcal glomerulonephritis in case of nephritic syndrome. Okay, so thank you very much for your patient listening. I've gone through this very rapidly because you guys have very less time left now for your exam. And I wish you all the best and just try to revise as much as possible. And you can go through videos already uploaded on my channel. So thank you very much for your patient listening.